Welcome everyone to this webinar on reporting race and ethnicity data in Lancet journals. I'm Zoe Mullen, the Editor-in-Chief of the Lancet Global Health and Inclusion and Diversity Lead for the Lancet Group. Today we have two speakers for you who are both members of the Lancet's internal Group for Racial Equity, or GRACE, and also journal editors. Mabel is additionally on secondment currently to another part of our publishing unit at Elsevier, where she's the Inclusion and Diversity Initiatives Lead. This is our agenda today. Pooja is going to take you through why we need better reporting of race and ethnicity data, and Mabel will then describe in more detail the Lancet Group's guidance on reporting race and ethnicity that we've recently released. And then we'll have a Q&A section at the end. So please do be putting your questions in the Q&A section throughout the webinar and at the end when we move into Q&A. A few housekeeping notes for now. Do submit those questions, as I mentioned, in the Q&A box. On the dashboard, you'll also see a related resources box, which contains useful links to content on thelancet.com. If you'd like to turn on closed captions or translations, click the CC icon in the top right-hand corner of the webinar dashboard and select your preferred language from the options available. Please note that the captions and translations are automatically generated and so may not be entirely accurate. You'll receive a link via email to the on-demand version of the webinar after the event has ended. And at the end of today's webinar, we'd appreciate it if you could please complete our 30-second feedback survey, as your feedback helps us to improve our webinar offerings in the future. So without further ado, let's get on with the webinar. Over to you, Pooja.
Thank you, Zoe, and welcome everyone. Thanks for joining for today's webinar. And before we start, I think it's very important to have a clarity on what race and ethnicity means, because there's a lot of confusion and often people misunderstand how race and ethnicity should be used in research. So the first and foremost thing is to understand that race and ethnicity are social and not biological categories. And this is often misunderstood because people relate race and ethnicity with biology, but actually it's not related to biology. So when it comes to race, it's actually a social construct historically based on perceived physical traits like skin color or facial features, and it has actually no genetic basis. Similarly, when it comes to ethnicity, it refers to shared cultural identity like language, heritage, religion, tradition, or national origin. And with more and more migration and people moving into different continents, the ethnic identity can shift across time and place. So that's why ethnicity, again, doesn't have a strong biological link. And it's also defined by social, historical, and political context. So, how should we use race and ethnicity in research? It should purely be used to describe to describe inequalities in health and research, and not to imply biological differences. And here on the slide, I have put a nice link to the JAMA guideline for using race and ethnicity. And if any of you are interested in delving more into understanding how it should be used, I would encourage you to use these guidelines. So then, why do race and ethnicity data matter? And the answer is actually very simple. It matters because everyone matters. Each and every person on this planet is important, and everyone matters. Everyone's voice matters, everyone's health matters. So we really cannot leave anyone behind. And to explain it in a very simple way, you can envision it like this, that if we do not have disaggregated race and ethnicity data in research, it's like having a blinded view of your research where you do not clearly see what is happening in your research. So here on the left, you will see a very simple depiction of what it means when data are not disaggregated. So the first bar, the yellow bar, is the average bar of mortality in a population. And this is just a hypothetical graph to give you an example. So if you take an average mortality in a population, you would see that, as it is shown here, the mortality is 15 per thousand, per 100,000 people in a population, and which is fine. You can say, okay, this is the mortality of a population, but it doesn't give a snapshot of what is really happening in the population. So when we tease out the actual data from different ethnicity in this population, you can clearly see that those belonging to the Black ethnic minority group have the highest mortality, followed by Asian and white. And even though this is an hypothetical example, in a lot of research, this is the general trend we are seeing. So in a nutshell, if we didn't have the clarity by ethnicity, it would be like having a blinded view of your research, and you can see it as a GP prescribing medicine to a population, to a group, without having a clear view of what it looks like. So it's likely that you would hit the target, but it's very highly likely that one would miss those who are most at risk. And that is why it's important to have a clear view of what is happening in in your research. And when we can see clearly, we can act effectively. And when we can see clearly and report it, then governments can take action on it. And if we do not report the data, it will be difficult for government or public health officials to take appropriate action. And that's why it's important to have these data. Now, the goal here is not to divide people by race and ethnicity, but to understand how society does and to measure these health consequences so that we can fix them. So, why do we need better reporting of race and ethnicity data? And there are three key reasons. Of course, there are many reasons, but there are three key reasons why we absolutely need race and ethnicity data. First, to uncover disparities that would have otherwise been missed in your research. Then, to increase the relevance of your research and also applicability of the research, because if the research doesn't represent the population, it is not applicable to the entire population. And at the same time, also to reduce the research waste, because if it's not done in a representative population, we are not doing justice to science and also to the taxpayers' money, because most of the research that we do comes out of taxpayers' money, which includes everyone. So it's really important to maximize the efforts researchers are putting into their research, and it wouldn't take much to add more or to acquire more data by disaggregating their findings in race and ethnicity categories. And the last, which is also the ultimate goal of science and for which we are all here, is to improve health outcomes and advance health equity. So in the coming few slides, I will touch upon these individual points, and I will show you examples from across the Lancet family of journals on how we have used research to fulfill these key reasons, how scientists are using their research to report race and ethnicity data and how it impacts the population. So, starting with the first example, we need race and ethnicity data to uncover disparities that would have otherwise been missed. So, we've just seen with a hypothetical example why these data are important. And here I have an example from a paper that was published in the Lancet Regional Health Europe last year. And this was a very interesting study because it reported the maternal mortality in UK from 2009 to 2019 based on the ethnic categories of all women during this time period. And as you can see from the graph, those belonging to the Black ethnic group had 4 times higher mortality than white women, and also followed by Asians. So this data is very important because presently there is a huge public debate in UK, and there is a huge interest in improving maternal care in the UK. And in June of this year, the government announced a national investigation into maternity and newborn and neonatal services in England. So these data go into policy making. When the data are there, government can act on it. If such data are not there, it will be difficult for people to act on it, because as they say, what doesn't get measured cannot be accounted for. So if we want everyone in our population to be accounted for, we need such disaggregated data. And these findings also complement and strengthen the evidence base that underpins the NHS England's equity and equality in maternal care strategy. And this strategy is specifically focused uh, on addressing disparities for uh, for underrepresented populations, for ethnic minorities, and those who are living in the most deprived areas in the UK. So such data are very important for policy making. Now let's look at the second example. We need race and ethnicity data to increase the relevance of the research we do and also to reduce research waste. Now here I have taken an example from a paper published in the Lancet Regional Health Americas in 2022. And it's a very interesting example because it shows the percentage of all clinical trials that have been done in US between 2000 and 2020, and whether these clinical trials reported race and ethnicity data or not. And you will see that less than 50% of the trials reported race and ethnicity data, and more than 50% did not report race and ethnicity data. Now, one can argue, okay, it's just 47% and it's quite good. So we are not doing too bad. But actually, it's not good, because even the ones that reported the race and ethnicity data, authors found that it was overrepresented in the majority population. So, and the minority group enrollment was well below the population benchmark. So the white participants from these trials accounted for 80% of the trial enrollees, when white population accounts for 72% of the US population. So they were overrepresented. So we can ask whether the research we are doing is actually representing our whole population. And actually it's not, even for the majority of the population. And this is very, very important to take note of. And actions should be taken to ensure that in future, when we have more clinical trials, there is a proper representation of the population where the clinical trial is being done. So that's why transparent reporting and inclusive recruitment would increase the generalizability of the research and also applicability of the results and reduce the research waste. So, coming to the third example for why we need race and ethnicity data, and it's to improve health outcome and advance equity. And one can say that this is a idealistic goal, and it's not very pragmatic that we would reach this goal anytime soon. And I hope by the end of the 2 slides that I show you, you will be convinced that it's not idealistic. And if more and more people report the data, then actions would be taken. So here is the example of a paper that was published in the Lancet in 2020 during COVID time, which was where we all know that during COVID, ethnic minorities were the ones that were most affected when you compare the entire population. So this particular study, it evaluated the seroprevalence of SARS-CoV-2 in a population in US. And you can see from the graph on your left that those belonging to the Black neighborhoods had the highest positivity, followed by Hispanics and then white neighborhoods. So here the data are very clear that there is something going on why particular neighborhoods have high seropositivity. So these data are very important because they can help to inform public health strategies. Because if we don't have such data, how would government or public health officials or municipalities know where they should target their interventions? And the whole population is affected. It's not that only a particular population or a group is affected for conditions like or pandemic or other infectious diseases. It doesn't stop in one boundary, it doesn't stop in one location, it spreads. So the economic costs can be reduced if targeted interventions are taken, and data like these help to make targeted interventions, and that's why we need such disaggregated race and ethnicity data. So let's look at the next example for the same point on why we need race and ethnicity data to improve health outcomes and advance equity. And here, the example I have taken is from the paper that was published last year in the Lancet Hematology. And this is a very interesting paper. It mapped the survival, 5-year survival of all patients who were receiving hematopoietic stem cell transplantation. And here you can see, if you see the line, the top line is the red one is for white people belonging to the white ethnic group, and the bottom one is those belonging to the Asian ethnic group. And it's very clear that Asian patients undergoing hematopoietic stem cell transplantation had worse outcomes, they had higher mortality compared to their white counterparts. Now, such data is again very important because once we have this data, further research can be done to understand why such disparities are happening, because these treatments are again expensive, it's government's money, it's patients' money. So if so much of uh, economic costs are going into such treatments, it's important to identify why we are not reaching the same level of treatment for all the population. So until we have such data, we cannot tease out what's happening behind and we cannot take action. So that's why, again, race and ethnicity data are important to understand what's actually happening in a country, in a continent, in our population. So, with my last slide, I'd like to close, and I hope that I've been able to convey with these examples why race and ethnicity data are important. Now, you may think, or a lot of people may think, that having race and ethnicity data makes us biased and it's not being neutral, and it's not important because it's important for us to be neutral. But as you've seen from the data I have shown from the examples, it's actually, if we don't have this data, we are then not being neutral. It's not having this data is opposite of neutrality, because if we have this data, we are being very clear, very transparent, and actually reporting what is happening in a population without being biased. So that's why I think the question about neutrality should be focused on involving everyone in a population. And it doesn't mean that every time when a research is done and we have disaggregated data, we will see disparities within different ethnic backgrounds. There will be a lot of instances where we won't see disparities, and this is perfectly fine because we want to report data as they are. Important is just to report it how we see it. And when we have more such data, I hope in 15 to 20 years from now, when we have had enough data, governments will be able to take action. And perhaps in 20 years, when we revisit our research, we wouldn't see a lot of disparities in the bar graphs that we've seen today. And hopefully then we would be able to make a difference. And I'd like to end my part on this positive note, that if we have more data, we will have a better science in the coming 15 to 20 years. So with this part, I'll end here and I'll hand over to my colleague Mabel Shu, who will take us through Lancet Group's guidance on reporting race and ethnicity. Over to you, Mabel.
To recognise the importance of more accurate and transparent reporting. So as part of this recognition, the Lancet developed its own guidance for authors on reporting race and ethnicity data, and we launched this in June last year. Now, I'll now take you through what the guidance involves with published examples of the guidance in practice. We developed this guidance in an iterative process. So it involved the Lancet Group's, the Lancet's Group for Racial Equity, otherwise known as GRACE, Lancet Group editors, GRACE's External Racial Equity Advisory Board, and other international experts, including some from low and middle income countries. So what do the guidance actually say? Well, we encourage researchers to recruit a diverse population for all the reasons that Pooja's already outlined, and to plan to report and analyze data by race and ethnicity, or both, race or ethnicity, or both. As Pooja's mentioned, this helps us to unearth disparities in our communities. So for research papers, we ask authors to disaggregate data on race or ethnicity with an explanation of the conceptual framework or categories used and how the categories were assigned. For instance, whether through self-report or census or registry data. In the example on the right, we see a national population-based cohort study from the Lancet Regional Health Europe. Actually, an example from a previous paper that Pooja mentioned. They described their categories as follows. Women's ethnicity was self-reported in their maternity records and classified according to 5 aggregate or high-level groups, and they named these groups, as well as 18 subcategories as used in the 2021 census for England and Wales. Then they list these in a supplementary table. They go on to define ethnicity as the ethnic group that the woman feels they belong to, which should be based on their culture, family background, identity, or physical appearance for consistency with other UK data and self-report methods. Now, we recognise too that categories are often imperfect and they will differ based on geography, local social context, databases, etc. So that's the reason we ask authors to explain what they used so that the reader can interpret the findings appropriately. If race or ethnicity data were not collected, we simply ask authors to give the reasons for this, not to find fault, but simply to help us understand the challenges in doing so. So, for instance, in this example from the Lancet Rheumatology, we have the statement, ethnicity data were not collected in the study because complete and standardized ethnicity records were not consistently available. Or another hypothetical example, race and ethnicity were not collected in accordance with local legislation, which we know is the case in some countries. Some authors have also told us, going back to the previous slide, that they were uncomfortable using the ethnicity or race categories in their database, given that these categories may have been quite outmoded. So they didn't feel comfortable using it. And if that's the case, please do say that, because it's useful, again, for readers to know what the challenges are, as well as how we may need to change our systems or processes or policies. Now, we also ask about factors further upstream related to the design of the study. So, for instance, in the methods, for research focused on minoritized populations, we ask how they addressed community engagement. Did they include authors from these groups? For research involving Indigenous peoples, the Consider statement, which is included in the Equator Network of Reporting Guidelines, is a useful tool to help you report this. The panel on the right shows the areas covered by the Consider checklist, and you can see it runs the whole gamut from governance all the way to dissemination. In the discussion, we also ask authors to discuss how representative their sample was. Again, discussing this transparently helps readers to interpret their data and to access the applicability of the findings to their own community. Here's a systematic review from the Lancet Healthy Longevity on the prevalence of dementia among Indigenous communities in high-income countries. As you can see from the authorship byline, looking from perhaps the second line down, the authors include people from some Indigenous communities. You can see the tribal affiliations in brackets in the byline. And this is Lancet practice when authors provide such affiliations. In another example, we see that this systematic review, it's the same example as the previous slide. We see that this systematic review applied the Consider tool in its application, in its evaluation of the quality of the studies in their review. We also see that they applied the Consider tool to themselves and completed the Consider checklist for their own study, much as you would a consort checklist for a randomized controlled trial. So they say, we evaluated the prioritization of Indigenous involvement and views by adhering to the Consider statement. Now, more accurate, transparent data reporting needs to go hand in hand with more accurate data interpretation. Because race is a sociocultural construct rather than a fixed biological trait, we ask that when discussing race-associated disparities, authors consider the wider context of socioeconomic or other structural drivers behind these disparities. And this applies to all papers, not just research articles, but review articles and opinion pieces, etc. I'll run through some examples in the next slides. We also ask authors to avoid race-based associations drawn from observational data, which can oversimplify things. Instead, we ask authors to discuss the potential limitations of such data and the possible role of unmeasured confounders. For example, a phrase such as disease X is more severe in Y race may end up, it may start in a paper, but end up echoing for years in lecture halls, tutorial groups, ward rounds, clinic consultations. Such statements can oversimplify the complexities behind observed associations and may unintentionally pathologize particular racial or ethnic groups. There is evidence that such statements can also skew clinical decision-making, some examples to follow, and worsen health outcomes. So perhaps a more accurate statement could be, disease X has been observed to be more severe in Y race, possibly due to systemic factors such as reduced access to care, which were not measured in our study. So explanations along these lines can reduce the potential for harm from oversimplified attributions. Now, in this analysis of national surveillance data by Reagan et al. In the Lancet Public Health last year, they found that people who are in certain racial groups, racial or ethnic groups, have a greater risk of adverse tuberculosis care outcomes. The discussion usefully explained that further research is needed to elucidate the mechanisms behind this greater risk. It then outlined the evidence for how disparities in socioeconomic status, comorbidities, health insurance coverage, access to timely care, and quality of local health service can affect health outcomes. In this next example, a review article from the Lancet Psychiatry states that disparities in substance use treatment outcomes for minoritized populations have been reported for decades. However, the correlation of socioeconomic status and racial or ethnic minoritized groups and other factors and conditions associated with lower socioeconomic status could have obfuscated the differences found. So because of this correlation, we need to better understand how inequities in social determinants of health affect health disparities in order for accurate assessment and reporting of differences in treatment outcomes by race or ethnicity in future. When interpreting findings, we ask authors to avoid a deficit discourse. So what does that mean? That's a description of disparities that simply focuses on the problems. And the problem with this is that it can not only perpetuate race-based stereotypes and have a potentially demoralizing effect on minoritized populations, it may also discourage health promotion and prompt authorities and organizations to deny communities the opportunities to explore their own capacities to thrive. For example, studies on cancer screening have shown that people exposed to negative disparity articles about their community were less likely to want to be screened for cancer compared to people exposed to more positive framing of such data. So we ask authors to take a strengths-based approach. And here's an example from an intersectional analysis of a New Zealand survey in the Lancet. It found some complex health and socioeconomic disparities between ethnic groups in New Zealand. The discussion then states, public social services, educational scholarships, and healthcare provision, particularly for Indigenous and minority adolescents from financially strained communities, will have a substantial effect on social mobility. Initiatives that enable young people's sense of pride in their own cultural diversity and respect for that of others are also crucial to health and well-being outcomes. So instead of just dwelling on disparities and the problem, this discussion outlines how communities might capitalize on their strengths to implement solutions. We also ask authors to avoid use of race-based reference ranges and algorithms that are often based on incorrect or poorly evidenced assumptions, and these can perpetuate inequities in clinical decision-making and healthcare provision. So some examples from a Lancet paper. eGFR. This is the equation used to estimate glomerular filtration rate or kidney function, and it questionably applies a higher value to Black people based on historic hypotheses on race-based differences in muscle mass with very little substantiation. However, this may mean that a Black patient with true renal impairment may have an overestimated eGFR or renal function, which could mean receiving nephrotoxic medicine or medicines that are toxic to the kidneys in doses that are too high, or for them not to qualify for renal transplantation, which amplifies racial inequities. So the authors here advocate for the use of other more accurate equations that don't adjust for race. In another example, eltrombopag is a relatively new drug used to treat some platelet disorders. Small early studies suggest its metabolism is reduced in patients of East Asian descent. However, these are small observational studies with high risk of selection bias that should be interpreted with caution and can't be reliably extrapolated to whole populations. Yet, on the basis of these small studies, some East Asian patients might end up receiving inappropriate doses. So the authors here call for all patients, to receive the same starting dose regardless of race, but then titrated as needed based on platelet response. So I hope this has helped you to understand how more transparent reporting and interpretation of race and ethnicity data can improve science and benefit society. We hope our guidelines help you in this process. We'd like to thank our colleagues, Diana Samuel, Zoe Mullen, the Lancet Group for Racial Equity, the Racial Equity Advisory Board, other global expert advisors, and our Lancet editorial colleagues for their advice in developing these guidelines.
Okay, thank you so much, Mabel and Pooja, for that great introduction to our guidelines and the importance of having these guidelines in our journals. So now we're going to move into some Q&A. Please don't be shy. Please add your questions, however silly they may be. There are no wrong questions. No one can see your questions, so we're the only ones that can see them, and so we won't read out names either. So if you do have any questions, this is a safe space for asking questions about something that's is a sensitive area. We understand that, but I think, as Pooja and Mabel have made clear, this is all about understanding the science. It's not about pointing out where people have done something wrong. It's about making positive statements about race and ethnicity, not about trying to divide people or trying to point out areas that are difficult for certain individuals. How can we make things better for everyone? So maybe I can just kick off with a few questions for you two, based on the guidelines, because these have been relatively recently released. And I guess people might be interested to know what the response from the community has been so far. So Mabel, maybe you could, I know you've done some work on this, could you just give us a sort of a brief overview of the response we've had, and because I think on the whole it's been pretty positive, right?
Yeah. Journals have a reputation for simply releasing reporting guidelines and then not really engaging with authors on how to implement them. So we were curious to know what authors thought about our guidelines, including sex and gender guidelines, which some of you may have heard about 2 days ago, the SAGE guidelines, as well as our newly launched Lancet Race and Ethnicity Reporting Guidelines, launched last year. So we conducted a survey across all Lancet journals in January this year and invited all authors who'd received a revision letter explaining these guidelines in the previous 6 months. And we got a quite a good, actually, response rate for an online survey of 22%. And among the 484 respondents, we found that nearly half, 46%, were already aware of this guidance before they got our letters. The responses also told us that adherence may not be as big a task as we may imagine. So about a third of respondents were already required to collect race and ethnicity data by their research programs. And about 2/3 said they didn't amend their papers in response to our guidelines, mostly because they felt it didn't apply. For instance, their research didn't include human data, or the paper already adhered to their guidelines, or these data simply weren't available to them. And among the 19% who did amend their papers, most found this easy to do, which was all very reassuring for us. Now, many authors also seemed open to these changes. About 46% said they were more likely to do things differently in their next project now that they were aware of these guidelines. And while we know that intent doesn't necessarily equate with behavioral change, it was a really positive signal for us of preparedness to change attitudes and behavior. So all in all, really encouraging. And obviously, we've moved beyond, we're using these data to try and work out how we can better help support editors, but also authors to understand the benefits of these guidelines and to help them adhere to them.
Excellent. Thank you, Mabel. It's good to know. So we have a few questions from the attendees now, and maybe I can address this one to you, Pooja. I think so. So at the beginning, you spoke a little bit about the concepts of race and ethnicity and the fact that they're not a fixed biological trait; they are more sociocultural. But can you maybe just share a little bit more about the difference between race and ethnicity and how and how that matters, really, I guess.
Yeah, so thanks, Zoe. And actually, this is a very important question because everyone gets confused, even I get confused. So I think the best practice is that when you report race or ethnicity, just use both race/ethnicity. And as long as you do that, you're perfectly fine because a lot of traits, when I say traits, not biological traits, the readouts in your research are interchangeable. So I would say just use both. Specifically, if I have to just explain in very simple term, when it comes to race, think about bodily appearance, hair, eye color, facial features, things like these can be attributed to race. When it comes to ethnicity, it's more about how one sees themselves in a community, in a society. So, belonging to a religion, belonging to a country, having a shared language. So, whenever anything is community based, we can broadly classify it as ethnicity. And when you're talking about traits, classify it as race. But again, traits, not biological traits, but the readouts in your research.
Super, thanks, Pooja. That's very clear. There's a question here about. I mean, we mentioned, I think, the fact that there were these sort of data are not always available. But how? Do you have any suggestions? Maybe, Mabel, you could try this one. How authors can interpret data where there are large gaps in the information.
I think the most important thing is to acknowledge the large gaps because we're all very much learning about these disparities and the best methods to tackle the issues that they raise. So if your database is collecting some race and ethnicity data, but not others, it's worth acknowledging this as a limitation possibly in your paper. There may be statistical ways also to handle this, but the most important thing, as we've already said, is just being transparent about the gaps. The other thing to do is to, I think, advocate and discuss with the database owners why these gaps might be in place. And there might be logistical reasons, there might be local sensitivities. It's really important to try and elucidate what these are, because only when we try and understand what the barriers are, what the challenges are, can we really hope to tackle them. So I think, the first step is to get the challenges out in the open.
Yeah,
and
absolutely.
Just to add, Zoe, just to add to this point on which Mabel also touched upon, there are some advanced statistical tools where you can impute data. Of course, it's not perfect, but they should try and use these statistical tools to impute the missing data and see how the results are. And these statistical tools are also very good in saying what is the confidence of imputed data. So I would also encourage them to use these statistical tools.
Good, great advice. Thank you very much, both. Yeah, and I think on the whole, though, it's about transparency, isn't it? It's about pointing out that there are gaps actually potentially could help to close them in the future.
Yeah, and I actually might mention there is another issue of slightly related, of having too small a sample of certain groups, and to the extent that disaggregating that data may potentially end up identifying the individuals involved, the participants. And in those instances, you know, we might say to authors, okay, this might be a case for aggregating that data with another minoritized group that might not be so small, in order to protect the confidentiality of your data. So there might be circumstances where aggregating it can be useful and indeed the ethical thing to do, but these are very much the outliers.
Yeah, thank you both. So I guess on a slightly related note, one of our participants says, we've done manual collection of ethnicity data in a maternity hospital and compared it to what was recorded on the electronic health record and found almost 40% discrepancy. Any suggestions on how we might improve this? Pooja?
Yeah, this is actually a very interesting question, and we would need to actually see how authors have collected this data and have more information before we can actually pinpoint what the reason is. But if I would have to broadly speculate, I would say with all these registry and biobank data, they are very large and the sample collection is different. And in a small population of sample for a research, perhaps the authors have focused on a particular community or a particular region that is overrepresented or underrepresented in different communities. So I would not be surprised if they have so much disparity, because it's very different when you compare a whole biobank or a registry or a single center or multi-center trial. So I wouldn't be too worried about this.
Okay, thank you very much. So this is an important question, I think, is on probably a lot of people's minds. So recent changes in the political climate worldwide have targeted research examining diversity, leading to some changes in medical research funding. How can we negotiate these changes? Who'd like to tackle that one?
So yeah, if I may, this is, of course, a very difficult issue, and a lot of people have been affected. And actually, we can't do much because, you know, at the end, if the government has decided, we cannot do much. But what we can do from our side is just be persistent and still do research, still collect the data if we can. So I think we don't have an answer that would solve the problem we are currently in, but I would say where possible, we just be persistent.
Yeah, I totally agree. I think there's something we can do as journal editors is to say things that perhaps the researchers can't say. So, for example, having this webinar even today, hopefully will encourage people to keep doing the work. Hopefully this phase will pass and we'll move back into a period where it's well, it will always be important to do this work, but it'll be recognized that it's important to do this work. So so for now, I think as Pooja says, we keep on. If we are somehow prohibited by law from actually publishing the data that we have, then so be it for now, but let's keep positive and let's focus on the science, because this is what it's about. This is about evidence-based decision-making and people's lives. It's not some kind of, you know, ideology. This is about the science. Okay. Let me see. We've got lots of lots of questions. I'm trying to figure out how many we can get through in the next 10 minutes. Thank you so much for all your questions. So one of the questions here is, some interventions do have race and ethnicity dose differences, for example, statins. Are there any instances, Mabel, maybe you can try and tackle this one, I know you're medically trained, where we're actually not taking into account different dosing strategies by race and ethnicity could actually be harmful?
Yes, it's a really interesting question, because I'm learning so much about questioning a lot of these underlying assumptions. I guess for me, if there are specific government guidelines that say you must not, or specific prescribing software tools that don't allow me to prescribe a certain dose because a patient comes from a certain ethnicity, then I have to go along with what the specific stipulations are. But I'm finding that a lot of these assumptions are, as I've shown in some of those previous slides, really have to be questioned. So I'm taking it with a grain of salt. There are often instances where I have looked at the underlying evidence and I think, actually, it isn't directed so much to race per se, self-identified or not, but there are other measures of function, for instance, platelet function, or looking at other measures of levels of hemoglobin, for instance. With drugs, I think that's the way that I would also go. Pooja, you and I have discussed this statin question, and I know you've got specific thoughts on that.
We were discussing about this. So what we didn't include in today's presentation is also ancestry, geographical ancestry, and genetics, because these traits, like, the dose of statins, and also, the dose of anesthesia, painkillers, they also have some genetic variants in different populations. So there are some genetic variants in certain populations that predisposes them to a higher level of, let's say, lipid markers, to lower level of lipid markers, or when it comes to monogenic diseases like lactose intolerance or sickle cell trait, it's a bit different, where we know a particular population has this particular trait, are predisposed to the disease, and that's slightly different. So when we talk about those concepts where there is genetic predisposition or there are genetic variants that can be associated to a population, there, I wouldn't call it race and ethnicity, because I think in today's webinar we have clearly described they are not biological. It would be appropriate to term them as population, in which exact population we see high variance, different variants, and that would be a biologically correct way to describe it.
Yeah.
And I should add too that I think with the case of statins, my usual practice is just to start everyone at the same dose and titrate it to actual LDL levels. And that seems to work.
And just to add to this point that Mabel said, we know from the genetics data that genetic variation within one population is much higher than genetic variation between two populations. So this is a clearly defined, not even concept, it's a fact. So this already establishes how, race and ethnicity do not fit here, and it's also variation, genetic variation, that leads to these differences. And this perfectly fits with what Mabel said, that we should titrate and then, come to the dose that works for the patient because of this variation.
Absolutely. Thanks for that, Pooja. There's a question here going back, I suppose, to the rest of the community and how it's been received. But one of the participants is curious whether we're finding that research ethics boards have incorporated these principles, or perhaps maybe funding bodies. Are you aware of any? Because as one of us mentioned, we're quite downstream, as journals. We can't really have very much influence at this stage on how the research was done, only how it was reported. But I think when you start to get things like funding bodies and ethics committees on board, that's when you start to see the changes. Have we seen any of that so far?
From the data that we collected in the survey, we found that 10 to 15% of responders said that their funders actually required them to collect these data. Now, I'm hoping that, with webinars like this, with guidelines that various journals are putting out or supporting, that and the advocacy that the Lancet Group is doing, and other journals, other publishers elsewhere as well, that will be able to shift the dial on this. We're certainly hoping to engage with research organizations and funders about eligibility criteria for their programs, and to, help them understand the benefits for science by collecting such data. So yes, it's only really when we change systems and structures and policies and practices that, we can see a real move in the dial for society.
Thanks very much. And then going into how the guidelines were developed, there's a question here about whether there were considerations for data governance frameworks such as OCAP and EGAP. I'm sorry, I'm not totally familiar with those. Hopefully one of you two are. So I guess, data governance frameworks. Perhaps we touched on the fact that in some jurisdictions, actually, it's not legal to collect such information, but maybe you should could just go over some
Correct.
of the.
And we recognize that there are boundaries for collecting such data for certain people, certain researchers, certain countries. And again, all we ask for is transparency in reporting those boundaries. We're not really in a position to mandate anything. It's simply about do what you can and tell us what you can't do.
Perfect. Thank you very much. So I think we're approaching the end now, but we've got in the last 3 minutes. Maybe we can just squeeze one more in. We've got quite a few questions coalescing on kind of the large sort of lumping categories we tend to get with things sort of like Black, Asian, white that are maybe not very descriptive in themselves. So if one of you maybe could just give us a quick sort of reflection on the usefulness of such kind of blunt ways of categorizing people, maybe we can finish there. Thank you.
So if I may, according to our Lancet guidelines, whenever possible, we prescribe that authors should use these terms as specifically as possible. For example, when you say Asian is very broad, Indians, Chinese, all different populations. So, for example, if you say Asian, if you can in your research be specific, you can say East Asian, or you can say Chinese, or you can say Indian, or you can say Malaysian, whatever. So if you can be as specific as possible down to the level of population, that is the most ideal way to describe or report your findings. But we understand that it's not always possible, because a lot of time it depends on how the data are collected, and if government is collecting the data, or a particular NGO or any different bodies collecting the data, they may have their own priorities on how they are collecting the data, so you would be limited in what you get. So as long as you have broader categories, that's fine. But if you're starting your own research, your own trial, retrospective or prospective study, if you can be more specific, that is more ideal.
And just to say, the main thing is to actually tell us what definitions were used, whether it was by the database owner or yourself if you collected that data. Just letting the readers know what you used is probably the most helpful thing as well, the other helpful thing.
Thanks very much, both. Okay, so I think that brings us to the end of our Q&A. Thank you so much to everyone for putting all your questions in. There's a lot more we could have got to, but I really appreciate everyone's thoughts on that. So if we just move to the last slide, we can leave you with our website, which includes a lot of more information that we've put together ourselves and that we champion on equity, diversity and inclusion. Please do go and check that out. So it just leaves me to say thank you so much to Mabel Chu and Pooja Jha for the excellent presentations today, and for everyone for joining the webinar. Enjoy the rest of your day. Bye-bye.
Thank you.